Good afternoon, everyone. Welcome to the second plenary session.
Now I request the chairperson, Dr. Krishnanand Kamath and Dr. Karunakar Hegde and the speaker, Dr. Grace Mary John, to take seat on the stage.
I request Mrs. Anvita, Faculty of Pharmacy, to florally welcome the dignitaries. Today, we have with us Dr. Krishnanand Kamath as the chairperson. Sir has completed his B.Pharm and M.Pharm from Manipal College of Pharmaceutical Sciences, Manipal, and PhD from Srinivas College of Pharmacy, Mangaluru. He has had industrial experience in quality assurance and R&D for 11 years. Later, in 2010, he joined as assistant professor in Srinivas College of Pharmacy, Mangaluru, and has been continuing in his role since then.
And we also have Dr. Karunakar Hegde, Professor and Head of the Department, Pharmacology, Srinivas College of Pharmacy, Mangaluru. Sir completed B.Pharm from National College of Pharmacy, Shimoga, and M.Pharm from KLE College of Pharmacy, Belgaum, and PhD from Rajiv Gandhi University of Health Sciences, Bangalore. He joined Srinivas College of Pharmacy in the year 2005 and presently working as Professor and Head of the Department, Pharmacology. He has published more than 90 research articles in the index journals. He has authored 1 book and 3 book chapters. He has received 2 times research grants from Rajiv Gandhi University Health Sciences, Bengaluru.
Sir, I request you to introduce our speaker, Dr. Grace Mary John, Infectious Disease Clinical Specialist and Chief Clinical Pharmacist in Believers Church Medical College Hospital, Tiruvalla, Kerala, to the gathering and to chair the session.
Well, good afternoon. It's an immense pleasure to welcome Dr. Grace Mary John for this plenary session. Dr. Grace Mary John completed his PharmD and she is the first and only American board certified infectious disease pharmacist in India, pioneering pharmacist-led antimicrobial stewardship programs. She is an international ambassador for Society for Healthcare Epidemiology of America and Board of Pharmacy Specialties. She has contributed significantly to the clinical pharmacy globally. She is employed at Believers Church Medical College Hospital as Assistant Director, HOD of Clinical Pharmacy. Also, she is a pivotal role in patient care, education and administration. Dr. Grace is President of the Federation of Clinical Pharmacists in India and holds key positions in the stabilization and inclusive development programs. Dr. Grace sought after a speaker. She contributes to AMS related discussions globally. She also serves as a journal reviewer for PLOS Global Public Health, bringing over 8 years of expertise in infectious disease clinical pharmacy. Dr. Grace is an Assistant Director, Infectious Disease Clinical Pharmacy Specialist and Head of the Department of Clinical Pharmacy version. Ma'am is also an Assistant Professor in the Department of Pharmacology for MBBS students at Believers Church Medical College Hospitals. She has undergone antimicrobial stewardship site observation at Detroit Medical Center, Karmanos Cancer Center, Detroit, Michigan, USA, and Tufts Medical Center, Boston, USA. She is a member of International Task Force and serves as a member of the Education Committee. She has been an invited speaker for various national and international conferences, including prestigious SISCON 2023, which has held in Chennai. She is also a journal reviewer for Fearless Global Public Health. So, Dr. Grace is gracing this occasion to enlighten us on the topic of practical implications of antimicrobial PKPD and dosing strategies. With this very brief introduction, I welcome you to this session. Over to you, madam. Thank you.
Thank you, sir, for the kind introduction. All right, good afternoon, everyone. So, respected chairpersons, principals, esteemed faculty, and students, I just wanted to know whoever is there in this in this hall right now. How many of you are interns, PharmD interns? Okay, rest of you? MPharm. PharmD? Third year? Fourth years? Fifth? There's a bunch who has not, pointed their hands. Okay, so first question, how boring do you think this topic is? The PKPD implications? Nobody thinks it's boring? No? All right. Okay. For the PharmD students who are here, I wanted to ask you some things that I always ask my students. Why did you take PharmD? No, seriously, why did you take PharmD? Anyone? I had my reasons, and I'll tell you, and you can, raise your hands if those were the reasons that, for you also. You will get the doctor tag. Yes? You can tell the doctors what to write. You can tell the doctors what to prescribe. So many opportunities abroad. Yes? You can specialize in certain areas after your PharmD. Other than that, what are the reasons? These were the major reasons for me to take up this, and one other reason was that I don't have to study physics. That was one major reason why I took PharmD, because I loved chemistry and I hated physics. Is there any other reason why you took PharmD? Okay, all right. And so far in your journey, how much are you convinced that you're able to do all these things that you said, that I've mentioned, that you can tell the doctor what to write, that you are the experts, the drug experts, you can go and tell the doctor, no, this is wrong, this is right. How many have felt that way so far? All right. Okay. I started just like any of you in this audience, okay, as a PharmD student. But one thing I wanted to do was that I wanted to be a clinical pharmacist for sure. I didn't want to go to the company side or research side. I wanted to serve with the patients, with the doctors in the medical team. So that has been my goal, and during my PharmD period, college time. And luckily I had the institution that nurtured my goals, helped me to achieve what I am today. And it took a lot of effort. It did not happen overnight. It happened over 5, 7, 8 years that I am standing here right now as a speaker to you. I had come to this college 6 years back. At that time, I was not a board certified person. I was not an infectious disease pharmacist. I was just a pharmacist, clinical pharmacist who wanted to become an ID pharmacist. Okay? So the reason why, actually they asked me for the topic, and I picked this topic because I felt that being a clinical pharmacist, your trump card when it comes to the battle with the medical doctors is your pharmacokinetics. Okay, I've learned it the hard way, so I thought I'll share some of the clinical scenarios that happens with us on a day-to-day basis, how we choose certain drugs and how pharmacokinetics, pharmacodynamics helps us in making that decision. So, like you've heard in the introduction, I am basically a person who loves antimicrobial stewardship. You know, stewardship is what? What is antimicrobial stewardship? The need for antimicrobial stewardship. Basically, it is the war, the antimicrobial resistance, the war we have against the superbugs. Okay? So when I started PharmD, when I was when I was a student, the most commonly written antibiotic, empirically written antibiotic was ceftriaxone. Ceftriaxone is a which generation cephalosporin? Third generation cephalosporin. You know what the cost of ceftriaxone is? Approx? Okay, I'll tell you. 1 gram of ceftriaxone will cost you 50 rupees. Okay, 50 rupees. So it was one of the most commonly used empirical therapy. Now we have infections where ceftriaxone doesn't work, meropenem doesn't work, your high-end antibiotics doesn't work, and you have to go to the highest end, which is in your knowledge the highest end that you know. Way high. The highest end for gram-negative organism. Have you heard of colistin, polymyxin? Ceftazidime avibactam? Ceftazidime avibactam, have you heard of it? So in our hospital setting, ceftazidime avibactam is the highest. Okay, and the dose of ceftazidime avibactam is 2.5 gram Q8H. 3 times you have to give the drug. And do you know the cost of that drug? Per day, easily it will cost you 20,000 rupees. Per day, easily. So this is the difference between not having antimicrobial resistance and having antimicrobial resistance. The same infection, the same E. coli that you used to treat for 100 rupees a day is costing the patient 15,000 to 20,000. The same bug. Only thing is that they have gained some resistant genes. But you need to spend 20,000 rupees to treat that drug. So this is our war against superbugs, antimicrobial resistance. This is the reason why we need antimicrobial stewardship. So that whatever you write now, you must make sure that you know that within no time this drug also will get resistant. This drug also will become futile. So what next? You will end up with no antibiotics to treat and you will have to watch your patient die in front of you because of sepsis, because you can't control the infection. Therefore, stewardship is one of the way in which, one of the key roles for a clinical pharmacist, especially in ID, in infectious diseases, that we can easily do, and that's what I am doing. That's what I am basically an infectious disease clinical pharmacy specialist doing stewardship. So, for any stewardship program, the Center for Disease Control, the center that comes up with the whole big guidelines, the COVID guidelines, the H1N1 guidelines, they have said that for any stewardship program to be running successfully, there has to be these 7 core elements. I just want to highlight 2 core elements in that. The second one, the accountability. The third one, the drug expertise. The reason why I am highlighting these two are in accountability and in drug expertise, they talk about pharmacist. Accountability can be with an ID physician or an ID trained pharmacist. In believers, it's a pharmacist run stewardship program. It's not a physician run stewardship program. Okay, in many centers, it's a physician run stewardship program. Because as per CDC, either the pharmacist or the physician can run the program. And the third one, the drug expertise, they say that if your stewardship has to run successfully, you need an expert of drugs. Now this is the multi-million dollar question for the clinical pharmacist. How can we become the drug expert? Right? We like to call ourselves, even doctors think just coming out of the PharmD course, oh, you know everything about drug. The reality we don't know anything about the drug. Right? So from there, how do we build ourselves to become the drug expert? So that's why I thought the PKPD, the pharmacokinetics dynamics is one area, if you home in on this area with your clinical practice guidelines, you will be way above your colleagues, your doctors. They will not be able to argue with you if you know your kinetics well. So certain examples I have. Again, the reason for stewardship is that, as you can see in this picture, in the 1980s and in the 1990s, there used to be a number of new antibiotics that comes to the market. Okay, right now we don't have many drugs because how much time does it take for a new drug to come into the market from drug development? How many years? How many years? Easily 15 to 20 years, 10 years minimum. It takes, no? So 10 years of investment for the company, and the moment you introduce that drug, the bacteria is very cunning that they become resistant. Okay, and within 10 years, again, your drug is out of the market because it can't be used because it is useless. So why should the pharma industry invest in antibiotics when they can invest in oncology, when they can invest in diabetics, where you have to take the drug lifelong? Okay, so the return of investment is not there for antibiotics. Therefore, again, the problem is that we don't have antibiotics and the resistance is increasing. So the one good thing that we can do is to make sure rationalize your prescription by exploiting the pharmacokinetics and dynamics. So you know the right R's, right? The R's, how many R's are there? Right patient, right drug, right dose, duration, administration. And when it comes to stewardship, there is one more thing, the right pharmacokinetic and dynamic parameters. So that the patient that you are treating will have minimal harm, and for the future patients, the resistance is not transferred by optimizing your therapy. Now, just wanted to touch through the basics because 4th years MPharm and 5th year, 6th years, you've all studied kinetics, right? 4th year is your kinetics, right? What is kinetics? Oh, that four letters, ADME, what is it? Yes, absorption, distribution, metabolism, and excretion. In simple term, what the body does to the drug. And what is dynamics? Which is either the pharmacological effect or the toxic effect, right? That is clear? Yes. So when you administer a drug, as you can see, over time, concentration, slowly the drug is absorbed, then slowly it gets distributed, alongside clearance will happen, metabolism will happen, okay? So this is the drug curve. Now, why are antimicrobials different from the other drugs? This is the traditional pharmacology. There is drug, what the drug does to the patient is dynamics, patient does to the drug is kinetics. Why is it different with antimicrobials? Yes, there is a third compartment, bugs. The PKPD has to work for the drug, not just for the patient but for the bug also. So it is not a two-way traffic, it is a triangular, it's a triad that we have to address. And how many of you know about MIC, minimum inhibitory concentration? Yes? What is it? So basically, if you have, in each of these test tubes, there is the same amount of bacteria. Okay, same amount of bacteria, but each test tube will have serial dilutions of antibiotics. So in the first test tube, the least concentration, then double, then double, then double. So MIC is nothing but when there is no visible antimicrobial growth. That means the drug is able to visibly inhibit antimicrobial growth. This is MIC. The reason why I am taking these basics for you is because my talk is going to be based on these things. Okay? And obviously you know the different categories, classifications of antibiotics, right? You have your chemical classification, which is beta-lactam, cephalosporin, fluoroquinolones, all these things are there. And mechanism wise also you have. So, no matter what you do, when it comes to antimicrobial therapy, it's very difficult to achieve your target. So, one way of exploiting pharmacokinetics and dynamics, this is one best example that everywhere is being quoted, is the continuous infusion versus the intermittent infusion versus the prolonged infusion. I understand you don't understand the thing of what I said just now. I'll come to that. Before getting into that, you've all gone to the hospital, right? You've all seen cases, right? You've all seen antibiotics being written. Okay, let's take ceftriaxone or meropenem. Which antibiotic do you see commonly, IV? Ceftriaxone. Okay. What is the usual dose? 1 gram? Yeah, OD is there, BD is there. So how do you give that 1 gram? IV as infusion over how many hours or how many minutes? So basically I am asking you, when you want to give an IV drug, what is the standard infusion time? Over what time do you give that infusion? Different drugs, it will be different. Like vancomycin, because of the toxicity, you have to give it over 2 hours or so. But usually, the standard infusion time, anyone? 30 minutes. Alright? So usually, 30 minutes is the standard infusion time. So here we are introducing a new concept which is purely based on pharmacokinetics and dynamics. Okay, so this one you understood, right? When you give a drug, the drug absorbs, or if it's IV, that concentration is there, then metabolism, distribution and excretion will happen. Okay, so this is your x-axis, this is your time axis, and this is your drug concentration axis. Clear? And you have a bug with an MIC of, let's say, that dotted line is your MIC. If you give a drug below the MIC, it will not work. That's clear, no? Because it can't inhibit growth. It has to be above the MIC. There are 3 classifications based on pharmacokinetics for antibiotics. I'll come to that. Time dependent, concentration dependent, and AUC by MIC dependent. I'll come to the time dependent one. So the concept is very simple. So here you have, this is the MIC, okay? And how much drug is there above the MIC? Only this much, right? And how much time is it? About this much time, right? Half of the time the drug is above the MIC, after that it falls below the MIC. Is that clear? Yes. So this happens with standard infusion. When you give over 30 minutes, all of a sudden there is a peak, and soon after that the metabolism, distribution, excretion takes place and it falls below the MIC. So there are a classification of drugs, basically the beta-lactam antibiotics, all your penicillins, cephalosporins, they come under time-dependent drugs. So it means that how much time you can extend. Like in that graph I showed you, at one point it goes down, right? But is there any way in which you can extend that time above MIC? So 3 ways you can do it. Either you can increase the dose. So the peak will be high, slowly it will come, right? Second, you can shorten the duration. Okay, instead of giving it as Q8H, maybe you can give it as Q6H. So intermittently you give, so the drug doesn't fall below the MIC. Or the third thing is, instead of giving as a 30-minute infusion, you prolong the infusion. You give it over 3 hours instead of 30 minutes. Okay, this is the third way of doing it. If you increase the dose or increase the frequency, toxicity can also happen. So the best way, easiest way is to increase the prolonged time. Now I'll tell you, so there are 2 ways of prolonging infusion. Either you give it continuously. Okay, that means if meropenem you want to give 1 gram Q8H, in one day you are giving total of 3 grams. So instead you give 3 grams over 24 hours. You do it, that is continuous infusion. Or there is something called as extended infusion, where instead of giving for 30 minutes, you give it for 3 to 4 hours. You extend the infusion time. Now I'll show you the graph. So the red one is your standard graph with 1 drug administration. Soon after, you can see here around 4 hours time, the drug falls below the MIC, because this is the MIC line. This gray bar is the MIC line. At 4 hours, the drug falls below MIC. Now, if you give it instead as a 3-hour infusion, you don't get a peak. You don't get that dose dumping all of a sudden. Instead, slowly the dose is being entered into the body. Therefore, what happens? Slowly the drug falls below the MIC. You get additional 2 hours. Okay? For continuous infusion, it never goes below the MIC. Okay? Now you tell me which is the best way of giving the antibiotic to a patient for such antibiotics. Continuous infusion. Okay? Second best, prolonged infusion. Okay? And least is your usual 30-minute infusion. This concept is clear, right? You can classify drugs based on this PKPD parameters. Drugs that work best when you increase the time above the MIC. Drugs that act best when you increase the concentration all of a sudden. And the third category where there is a mixture of both. I'll come to that. So this is one example of meropenem that was done. And you can see here, like I said, this is the standard, this one is the standard infusion. 30 minutes, the drug falls below MIC at 4 hours, but when you give it as extended infusion, you get additional 2 hours. Okay. I'll just skip through this one. So, prolonged infusion is a way because it has been proven that it helps in reducing the mortality, favorable outcomes with total daily dose, even length of stay and cost effectiveness, because the patient is getting better much earlier than before. Okay? But there are some practical implications that if you want to give it as a continuous infusion, you need 1 IV line just for that. And it's practically impossible to have 1 IV line just for that. So that is the reason why continuous infusion is not so much advocated for, but instead you prefer giving extended infusion. Then again, stability. Meropenem, if you look at the label, meropenem once reconstituted the stability is only for 4 hours. After 4 hours, it degrades. So you can't give meropenem over 24 hours. Okay, so that is also out of the question. So all these things matter, and there are incompatibility with other drugs. I will skip through the incompatibilities. Yeah. So unless I'm telling you evidence-based data, you shouldn't listen to me. Even if it is so sugar-coated that the concept is very, attractive, unless it is evidence-based, you should not enter into such practices. So what is my evidence? There was the Blink 15, in 2015 there was the Blink 2 randomized control trial which said it is not so effective. In 2017, 2018, two meta-analysis said yes, when you give antibiotics, especially piptaz and meropenem as extended infusion, it has better benefits. Even in surviving sepsis guidelines it came, but the latest trial that came in JAMA, the Journal of American Medical Association, said not that it is bad, but it doesn't have much effect. But we are awaiting the Blink 3 trial, which has the highest population of patients, 7,000 patients, head-to-head comparison for meropenem and piptaz, and we will await that trial. And most likely, I hope the trial comes up with the data saying that yes, please give it as extended infusion. Now, in the meanwhile, this is, just read through this topic, this heading. This is a guideline, okay? This is an international consensus endorsed by American College of Clinical Pharmacy, British Association of Antimicrobial Chemotherapy, Cystic Fibration Foundosis, ECMID, IDSA, SIDP, SSEM. All the societies came together to address this issue, whether to give beta-lactam antibiotics as extended infusion or not. So this is the evidence that I am telling you. All these societies came together and they suggested that yes, when you have a severely ill patient, the data suggests that for gram-negative infection, you treat the patient with extended infusions than standard infusions. So this is like a low-hanging fruit of stewardship, that you are not telling your doctor, no, this is wrong, right. You are suggesting to them something that is better, that can have better survival rates. You tell them, sir, instead of giving 30 minutes, can we administer it over 3 hours? You are not conflicting anyone. But this is purely based on pharmacokinetics. This is based on the time-dependent effect of the antibiotic. But they say that for non-severely ill, the patients who are in ward, who are not so sick, may not be. You don't need to give it over 3 hours because the data is not so robust. Because other practical problems are also there in ward. How long can you, rent this syringe pumps and other things? The logistics won't work out in for non-sick patients. For ICU critical care, yes, always give meropenem piptaz as 3-hour, 4-hour infusion. And whether loading dose, so the first dose that you give is a loading dose, right? So the loading dose, whether you should give it as 3-hour infusion or 30-minute infusion. It has to be given 30 minutes. It has to be rapid. Even if not even 30 minutes, some drugs you can even administer over 2 minutes. Okay? Loading dose is very essential so that your drug goes above the MIC. Okay? Unless your drug goes above the MIC, if you give it slowly, it won't, that effect is not prolonged. So the first dose, never ever compromise your loading dose. Never ever tell your nurse to give the first dose as 3-hour infusion. Always tell them the first dose should go within 30 minutes. Second dose onwards, subsequent doses, you have to give it over 3 hours. All right. Now, this was a scenario that I used to face a lot, because you have all these CKD patients coming with sepsis and all other kinds of things, and your doctor wants to give piperacillin and tazobactam. Okay? Based on the CKD thing, there are these two doses This dosing per day is the same. You either give it as 4.5 gram 2 times a day or 2.25 gram 4 times a day. Which one would you suggest? Which one would you suggest? For Piptas, meropenem, does the peak matter? Does the peak matter? The first loading dose has to be 4.5, no doubt about it. Does the peak matter? For time-dependent antibiotics? It's the x-axis that matters, the time that matters. So instead of giving 2 doses like that, it's better that you give it more frequently. So when you have such scenarios, it is your clinical pharmacy intervention to tell them that because it's a time-dependent antibiotic, instead of giving it as BD, it's better to give it more frequently so that your drug stays above your MIC. Okay? So this is concept number 1. So piperacillin, tazobactam and meropenem for critically ill patients, always give us 3 hours. Always give the loading dose, and when it comes to Piptas and meropenem, if you have more frequent dosing, go for the more frequent dosing than higher doses once or twice a day. Alright, now there are 2 more categories of PKPD classification, that is the concentration dependent antibiotic. So I said for time dependent antibiotics, the x-axis matters. Only this axis matters for time dependent. But when it comes to concentration dependent antibiotics, only this axis matters. It doesn't matter whether it falls down the MIC, because concentration dependent antibiotics, mostly they come under the category of protein synthesis inhibitors. If you look at antimicrobials, can you give me some examples of protein synthesis inhibitors? Aminoglycoside, tetracyclines, chloramphenicol. What are they? If you look at the time dependent, most of them are cell wall inhibitors. See, the good thing about protein synthesis inhibitor is that it goes and inhibits the 50S or 30S, right, ribosome, and it inhibits protein synthesis. So even if the drug concentration falls below MIC, for the bug, it takes time to reproduce that proteins. So that is called as a post-antibiotic effect. Even if that one dose that you give, even if it falls below MIC, that drug continues to act, because for the bugs it will take more time to become back to normal. Alright? So the best example that I can give you, as you can see here, is your aminoglycoside. So the various studies have said that, showed that aminoglycosides, earlier when I used to practice, aminoglycosides, for example, amikacin, it used to be given as 5 mg Q8H. Okay, it used to be given over 3 times a day. Now, the guidelines suggest that it's a concentration dependent antibiotic. The x-axis doesn't matter. For them, the concentration matters. Therefore, all together you give it as OD. So, instead of 5 mg Q8H, the dosing for aminoglycosides is 15 mg per kg OD. This is for patients with normal renal function. So, I am just introducing the concepts to you so that you can go and learn about it further. And then there is a mixture of other drugs like fluoroquinolones, vancomycin, where it's a mixture of both. Okay, it is the area under the curve that matters over MIC. So how much that comes here matters. Both the concentration and the time matters here. One good example that I can give you again is vancomycin. There was this landmark study that said that if the AUC by MIC ratio of vancomycin, so basically if you need to know AUC, MIC you get it from microbiology lab for your Staph aureus MRSA. Okay, my MIC is 2. Okay, the lab is giving me MIC of 2. For you to measure the AUC, you need TDM. So if you have TDM and if you measure the MIC, this is the study I'm talking about, not that it is practical in every case in your hospital. But in this study what they did, they measured the AUC, area under the curve, and if the area under the curve by MIC ratio was above 400, it showed that there is better chances of clinical efficacy rather than AUC by MIC ratio of less than 400. That is the study. So, one simple thing that I can ask you, let's say the AUC is 400, okay, and you have your lab report saying that your MIC is 1. So, AUC by MIC is 400 by 1, which is good enough. You can continue to treat. Okay, next patient, AUC is again 400, but the MIC of Staph aureus for vancomycin is 2. What is your AUC by MIC? 200, which helps us predict that that patient will go into clinical failure if the same dose is being given. Instead, you can hike up the dose so that you get the AUC by MIC above 400. So that was a landmark study. So with that, I will just finish the PKPD classification of antibiotics. So I have a case for you. We have an 80-year-old patient, obese patient, 82 kilogram, height is only 152, hypertensive diabetic, 25 years with lower urinary tract infection, creatinine of 1.4. Culture shows a gram-negative bacilli and sensitive only to amikacin or gentamicin. So, how do you calculate your creatinine clearance? CG formula? Okay, this is one formula every pharmacist should be able to say even from their sleep. Okay, 140 minus age into 140 minus age into weight divided by creatinine by 72. Alright, so like I said, for this patient, my physician, the creatinine clearance was 50. And my physician advised a dose. I told you aminoglycoside, the dose is 15 mg per kg once daily. So 15 mg per kg for this patient, it came as 1 gram. Okay. Luckily, she called me, my physician called me and asked me, Grace, could you please check the dose? Alright. Now I'll tell you what happened. Problem with weight-based dosing is we have 4 body weights. Do you know that? One is total body weight. If I go and stand on a scale, what does it show? That is my total body weight, ideal body weight. Okay, I am a bit obese. So for my height, I should be around maybe 75 kilograms. Okay, that is my ideal body weight. There is adjusted body weight. What is adjusted body weight? Let's say for a person, if 50 kilogram is their ideal body weight, but that patient is weighing 80 kilograms, okay? 30 kilogram is extra. So do you think that 30 kilogram is fully fat? Is it fully fat, that extra kilogram? Usually in that extra 30 kilograms, 40% is muscle mass. The rest is fat, okay? Why am I saying about this? In adjusted body weight, you calculate for the additional muscle mass also. You exclude the fat, but your ideal body weight with 40% of your extra muscle mass will give you the adjusted body weight, and there is something called as lean body weight, that without any fat, what is your weight? Is your lean body weight. Now, the question that I would like to ask you is that among these 4 weights, which one do you take for drug dosing? You have 4 weights. Which one will you take for drug dosing? Ideal body weight. Okay. Alright. That's where your kinetics come. You have to classify your antibiotics into hydrophilic and lipophilic. What is hydrophilic? Water loving. So, whatever loves water, whichever antibiotics love water, they'll go to the water compartments including your muscles. Okay? If it is lipophilic, it is lipid loving, right? It will go into your lipid compartments. It will distribute into your lipid compartment. Okay? So, let me ask again. We are talking about a case on aminoglycosides. Aminoglycoside comes under which category? Hydrophilic. Sure? Polar. Yes. So, for this patient, for this case, problem number 1, the patient is obese. Okay? No matter what you give, it will not go into the fat compartment. It will stay in your water compartments. Okay? So, for this patient, you have to take the adjusted body weight, not the total body weight. Okay? What was the total body weight of the patient? 82 kilogram. Now, what is the adjusted body weight? So, how much kilograms is she now less? 22 kilograms. Okay? Again, creatinine clearance. Based on what body weight will you calculate your creatinine clearance? 140 minus age into body weight divided by creatinine into 72. Which body weight? If I am obese, if I am lean, if I am ideal, my kidneys are going to work the same. Okay? Unless I am a diabetic, I am a hypertensive with kidney disease, my kidneys are going to do the same job. Okay? So, always calculate your creatinine clearance based on the ideal body weight. Okay? Otherwise, you might underestimate or overestimate your creatinine clearance, because most of the drugs, the body weight matters when it comes, the weight based is what your creatinine clearance is, no? So, again, when you calculate, earlier it was 50, creatinine clearance was 50. Now, it has come down to 32. And like I said, this 15 mg per kg is for patients with normal renal function. Is this normal renal function? 32. Which CKD stage is this? CKD 5 stages. Stage 1, 2, 3, 4, 5. 5 is the end stage. 0 to 15, 5. 15 to 30, 2. 30 to 45, 3B, 4, 3B, 45 to 60, 3A, 60 to 90, stage 2, above 90 with kind of microalbuminuria, stage 1. So, this patient comes under CKD, so you can't dose the patient. Oh, sorry, I had one more writing behind it. Like I said, what was the dose my physician wrote for this patient? 1 gram OD. You know what was the final dose that came? 350 mg OD. Just imagine an 80-year-old patient being pumped with 1 gram of amikacin, already CKD. She will go into nephrotoxicity, she will end up with acute kidney injury if we hadn't reduced the dose. So, this is again purely kinetics. This is again purely pharmacokinetics and practically applicable kinetics. Okay. One of the common scenarios that we have is sepsis. Okay? In critically ill patients, if you see, sepsis is the most common problem. What is sepsis? It's nothing but a dysregulated immune response to an infection. Okay? What happened in COVID? In COVID, the lung disease was because of the COVID virus. Was it because of the COVID virus? The patient who went into ventilators? What happened in COVID? You know, a lot of people ended up with ventilators. Why? Cytokine storm. You've heard of that. What happened? Because there was virus, and the virus, because it was living within the cell, our body made a huge response towards the virus that it ended up killing most of the normal lung parenchyma also, resulting in lung failure, okay? Respiratory failure. That's why many of the patients went into ARDS in COVID. Not because of the infection as such, it was a dysregulated response, autoimmune response towards the infection. Similarly for sepsis, Even if it's a small UTI, urinary tract infection, the body responds in such a huge way that the patient goes into all these problems. There is so much hemorrhage, so much vasodilation, hypotension. It's just a nightmare about the sepsis. So in sepsis, what happens is that the concentration of drugs, it just goes up and down. Okay? Easiest thing I'll tell you. Have you heard of the surviving sepsis guidelines? I have talked in my talk, maybe one part about it for that trial data. Okay. Like for every disease you have the major guidelines, right? How to treat that disease. You have guidelines. For sepsis, it is the surviving sepsis guidelines. So there is a bundle. If you have a patient with sepsis, step number 1 this, 2, 3, 4, 5. There are 5 to 6 measures that you have to do within 1 hour. Within 1 hour. Okay? The first and foremost management in sepsis is that if you have a patient with sepsis, pump the patient with IV fluids. Okay, that is the first and foremost thing. IV fluid management is a basic thing when it comes to sepsis. Why am I talking about this? When you pump your patient with fluid, your what compartment expands? Which compartment expands? Your water compartment expands. Therefore, drugs that are hydrophilic gets distributed even more. Okay? But the drug also has to come to the source of infection to act and get rid of the infection. So in such cases, it is very important that you know your, I'll just skip through this one. I don't think I should waste my time on this one. Okay. In sepsis, what happens is that because of the dysregulated immune response, you have a lot of vasodilation, you have hypoperfusion, and you end up with multi-organ dysfunction. The first organ that gets knocked out is usually the kidney. In sepsis, the creatinine just goes up. It is because of the vasodilation, the blood flow to the kidney is on the lower side. It is very sluggish, it slows very slowly. The blood moves very slowly to the kidney, therefore causing hypoperfusion, therefore the creatinine increase. It's not that the kidney has shut down. So it is the acute kidney injury. So there, your problem is that you either end up underdosing the patient or you give more and give toxicity to the patient. In kidney injury, what are you worried about? That the drug doesn't go out of the system and adverse reaction will happen, right? That is your major concern. But more than that, in sepsis what happens is that you end up giving a lower dose and you give a subtherapeutic dose and the infection will stay there. So again, I have just highlighted beta-lactams. Here also they have said the first dose you should double your dose when it comes to sepsis because you're pumping your patient with fluid. Beta-lactams are hydrophilic, they distribute widely, therefore you increase the dose. You don't immediately go and adjust your meropenem to 500 mg. You give 2 grams of meropenem, first dose. Then you see, and if it is acute kidney injury, again for the first 24 hours, you should not reduce the dose. This is a common mistake that I see. If there are working clinical pharmacists here, I know this will make a lot of sense to you because this is a common practice. Immediately you see creatinine 2, you cut down your dose. That's wrong. If it is sepsis-induced acute kidney injury, you have to give for the first 24 hours the full dose because once the infection gets controlled, the sepsis will automatically get controlled, your creatinine will come down. So the first 24 hours do not touch the patient. Okay. So the new labels that are coming for critically ill patients with AKI, they are saying for the first 48 hours, don't adjust the dose. So this is what we do in Believers. If a patient comes with acute kidney injury in our ICU with sepsis, for 24 to 48 hours, we will watch the patient. If the patient is having good urinary output, we will not reduce the dose, we will give the full dose. After 48 hours, if still the creatinine is going up, the urine output is coming, then only we'll adjust the dose. These are all simple things. The doctors, they don't know this. I'm telling you, they don't know this concept. This is our area of pharmacokinetics where we have to tell them the reason why we do not adjust the dose for 24 to 48 hours. This is how you show your expertise. Okay? All right. Now again, based on the site of infection again, what penetrates the lung? Okay? If it has to penetrate the lung, it has to have, it should be more of lipophilic nature, and hydrophilic drugs, they don't usually penetrate your lung very well. One good example that I can give you is linezolid versus vancomycin. It has been proven that linezolid is superior even if it's a bacteriostatic agent. Linezolid is superior to vancomycin when treating pneumonia. Alright, so this is again based on your site, what drug will reach there also matters. If you give IV and if your drug doesn't penetrate your bone, there's no point treating that patient with osteomyelitis with that drug. Similarly, for CNS, you need to choose something which something that is small, which crosses the blood-brain barrier, which is lipophilic, which has low protein binding, and the systemic dose will not cause toxicity, because usually in CNS, the dose that we give is double. So if you have to give such a dose, your systemic dose should not cause toxicity, and also intrathecal administration is something. Again, when it comes to skin and soft tissue, patient, see, one of the major things that you will see is diabetic foot infection and cellulitis. Most of these patients coming with diabetic foot infections and cellulitis are diabetics who are already having peripheral vascular occlusive disease. That means the blood flow is not so good. So if the blood doesn't flow very well, the antibiotic also wouldn't reach there well. Okay, therefore you have to choose your antibiotic very appropriately. All right, this one I've told you. Distribution also I've told you. Again,
another 5 minutes.
Yes, sir. Yes. One thing that I wanted to tell you is that protein binding is extremely important. One drug, maybe you have heard of it, ertapenem. Ertapenem is a drug, carbapenem drug, that is the choice of treatment for ESBL infection. The dose is 1 gram OD. Okay? But if you are having a patient that is having hypoalbuminemia, albumin less than 3, you cannot give ertapenem. Why? Because ertapenem is a highly protein bound drug. 90% of the drug is protein bound. So you tell me what will happen in hypoalbuminemia. For a highly protein bound drug, what will happen if the albumin is low? That means toxicity will be more, right? Yeah, that is again the misconception. Because in hypoalbuminemia, even though the protein is low, dose dumping is there. All of a sudden, instead of the protein the drug getting bound to the protein, lot of free drug is there in the circulation. But instead of causing toxicity, you know what happens? Pharmacokinetics, then dynamics. Instead of the toxicity, clearance will happen. The drug that is free drug easily get cleared out of the system, causing therapeutic failure. You will think that it will, because of hypoalbuminemia for a high protein bound drug, it will cause toxicity. But in reality, clearance will take over and will cause subtherapeutic concentration and will cause a clinical failure. These are all real life scenarios that we deal with. We'll see a drug, patient having albumin less than 3. If the drug is very protein bound, we actually tell them better to change to some other drug because of the therapeutic failure. Again, drug distribution I have already, I don't know why this came again. Going back. All right. Again, antimicrobial concentration is also important. If you have ever worked in gastro, how many of you have worked in gastro? Okay. Any patient with peritonitis, I give you 2 choices. Which one would you give? Ceftriaxone for SBP or cefotaxime for SBP. Both are third generation cephalosporins. Because of the lack of time, I'll just go. You can see here that this is cefotaxime, this is ceftriaxone. The amount of drug that is the drug that goes into the ascites for cefotaxime is 120% versus ceftriaxone is 50%. That's why in gastro guidelines you will see cefotaxime as a choice of therapy, empirical therapy rather than ceftriaxone. These are all based on evidence, based on kinetics. So the way ahead for us is definitely therapeutic drug monitoring. I will not go into therapeutic drug monitoring. In 10 years time, I truly believe that precision dosing based on therapeutic drug monitoring will have a long impact in reducing the toxicity and achieving our therapeutic targets in a better way. Due to the lack of time, I think I'll just end here. So your antibiotic selection has to be based on the microbiology, based on the patient characteristic, whether the patient is CKD or CLD, whether the site of infection, whether it's CNS, whether it's lung, whether it's urinary tract, which drug penetrates where, and the antibiotic characteristics, that is nothing but the PK/PD. So putting it all together, if you know your kinetics and your dynamics very well, you will become the drug expert and your doctors will ask you, will depend on you for expert opinion, and that's how you slowly learn to become a drug expert. So with that, you get your targets, and thank you. If you have any questions, I'll take them. I'm sorry, I know it's been quite extensive, but I'm only trying to say was that this is the level at which you can work. Okay, in clinical practice, don't let anyone else tell you clinical pharmacy is not a good job profile. It is a very rewarding, very, it gives so much happiness that you contributed towards the patient when you talk with the patient. So never let anyone tell you clinical pharmacy is not a good job profile, because those who are working in clinical pharmacy, those who are able to prove themselves in clinical pharmacy will have the best job satisfaction, and I can tell you with my experience. So I hope that you learn more about your clinical practice guidelines, your PK/PD, and you become the drug experts that you dreamed of when you started entering into this course. Thank you.
Thank you, madam. Yeah, open for questions, discussions. Any questions? Okay, fine. To conclude, madam, please. What is the present scenario, the Indian scenario? The hospitals having all this, the kind of dosing or the decision making in case of antibiotic treatment, and how it can be monitored, or by the government agencies or anything, platform is there?
So are you talking about therapeutic drug monitoring, precision dosing?
Not precision dosing, especially PK/PD, because your area is PK/PD. It is directly related to the dynamic aspects. Now, how it can be monitored in the hospital setup?
So one way of doing it that I have not done myself is like all these studies that I've talked about, like even for time-dependent antibiotic, what they try to do is that they know that certain things are the optimal pharmacokinetic parameters, and they tried clinical studies with it. Patients, example like meropenem 30 minutes over 3 hours, they tried to see whether it made a statistical difference in terms of clinical cure, clinical efficacy. Because when you start talking about pharmacokinetics, they'll all say, oh, it's all theory. They'll all say that it's all theory. But it's, unless you have clinical data backing it up, saying that, okay, for this patient it only took 5 days to improve, for the other patient it took 7 days or 8 days to improve. And it is statistically significant. That is one way in which we can bring out evidence saying, backing up our pharmacokinetic optimization suggestions that we are saying.
Fine. Other than this PKPD, now what other suggestions or the tips you can give to your PharmD students, making a better choice of antibiotics to the particular patient? What tips you can give?
See, like I said, for me, I also started like any one of you, like any of your, I also struggled throughout my PharmD. Not struggled, I was actually very happy with my PharmD because I didn't have to do anything. I had to pass my exam, go show my face for rounds, but responsibility was not there, right? That was the one thing that I lacked when I was doing my PharmD, that you're not responsible for any patient or any doctor or so you feel so free, you feel you are doing such a great job unless you end up in the hospital being a staff, where all of a sudden you have to become responsible, you have to prove them that you know something. Okay, so the struggle was real, but for me, with God's grace, I was able to build on whatever struggles I had. I had to home in on one area, antibiotics, antimicrobial resistance, and slowly, it took me years. I graduated in 2015 November. I got my job in 2016 January. For me, the board certification came only in 2021. It took me 5 years for the board certification. And throughout that journey, I started learning more and more things, more and more about stewardship, more and more about microbiology. Slowly, you will have to build. And the first and foremost thing I always talk for the 5th year, 6th years, this is the end of your rope, even if you don't realize it. This is your time to study the clinical practice guidelines. If you want to make a difference with the doctor that you are working, unless you have the clinical practice guidelines, they will totally disregard you. Because they are already practicing those guidelines, and you calling yourself a drug expert, not knowing the guidelines, is a big no-no for them. So, learn the guidelines which is not there in our curriculum. We are learning pharmacotherapy, Dipro and everything for the exam sake. But when it comes to the cases, you need to know for cardiology, you need to know the ACC guidelines or AHA guidelines. Similarly, for each posting that you have, try and read that specific guidelines. All you have to do is, myocardial infarction, clinical practice guidelines. So the top one will come as AHA, ACC guidelines. So for meningitis, clinical practice guideline. The IDSI guideline will come on top. So based on that, you read the guideline, you build on your knowledge, then you become better clinical pharmacists. That's how I learned. I learned it the hard way, but I'm happy that I took the route so that I can show you that it's possible to become a specialized pharmacist working with a group of doctors. In Believers, we have 65 clinical pharmacists. 65 people we have employed there. So it's not a small number. We feel that, and they are all very happy doing what they are doing. Okay, so they make a lot of difference in our hospital, and that is something that easily everyone can do. And slowly, the salaries initially doesn't matter, as long as in that first 5 years what you do, make yourself that stand, make yourself that expert so that they'll pay you more. Okay, so initially that first 2-3 years you have to build on your knowledge. Then only you can become a drug expert.
Yeah. Thank you so much. So informative sessions delivered by the Dr. Grace John Mary, and I hope the delegates have filled with the confidence how best they can become the clinical pharmacist or become the expertise in the clinical pharmacist. Thank you very much. By this I conclude this sessions. Thank you.
I would like to thank Dr. Krishnanand Kamath and Dr. Karunakar Hegde for being with us for the plenary session. Thank you, sir. And I also thank Dr. Grace Mary John for their wonderful session.
Now I request our principal, Dr. A.R. Shabaraya, to present a memento and certificate to Dr. Grace Mary John. I again request our principal to present memento to chairpersons.
We extend our heartfelt gratitude to the esteemed evaluators for their valuable feedback and support, and we are honored to present them with a token of appreciation as a moment of their collaborative effort. I request our principal and director, Dr. A.R. Shabaraya, to present a memento to Dr. Ajit Singh, Research Scientist, Kasturba Medical College, Manipal. I again request our principal, sir, to present a memento to Mallikarjuna Gowda, Principal, Prasanna College of Pharmacy. Thank you, sir.
As we have wrapped up to today's scientific session, we are thrilled to join you again tomorrow for the rest of the session. Looking forward to seeing you all tomorrow. Please note, high tea will be served at 3:45 p.m. Simultaneously, poster session will be going on.